Yeah, so today we are going to discuss hypertension. I think that is something that probably most of you have come across in their internal medicine rotation. And for those who don't know me, I'm Joan Kiyeng. And I think just to go to the introduction, sorry, I wasn't able to get Kenyan data on hypertension, but I think there are some studies that have been done in Kenya, in Western Kenya, just looking at the prevalence of hypertension, and it is actually quite high. It is something that it's a condition that it's quite common, and there is a lot actually to hypertension that you might think it is basically one of those big topics in internal medicine. And just looking at this data that I got for the US from the CDC, so they said nearly half of the adults in the United States, about 108 million, have hypertension, and or they are taking hypertensive, antihypertensives. And so as you can see, it's pretty common. And about those 1 in 4 of those adults have controlled hypertension. Back in the days, we used to say that patients who hypertensive, you have like 50% of patients know that they are hypertensive, okay? And then out of those 50%, only 50% have their blood pressures on target. So as you can see, it is pretty undiagnosed and also pretty well, not well managed. And I want somebody to take a guess, like what is the probably prevalence of hypertension in Kenya? Charles, you may need to answer yourself.
Oh,
what
look,
do you think is the prevalence?
I'm not sure of the prevalence in Kenya. Maybe if I check later on.
Mm-hmm.
Yeah.
Okay.
Seeing this thing,
and
not so
among good. Patients that you see, among patients that you come across, how many of those are hypertensive? It's a rough estimate. I just want you so that you will be having this in your mind when you're seeing patients.
About 3 in 10.
Okay. So the study that actually was done in Western Kenya showed pretty high prevalence. It was a study done in Busia. I'll refer you guys to check, but it talked about almost something like 85%, but I'll have to double check that. So, you know, also the cutoff for hypertension have been different since they've been changing guidelines and this, depending on the studies that have been done. So previously we were using what we called NCH that came in 2014, and the cutoffs at that time was 140/90. But they've been guidelines that are coming with different cutoffs. So of course that will interfere with prevalence. So I want the whole class to, after this, at least check and make sure we know the prevalence. I've tried to look at we have actually Kenyan cardiovascular disease guideline. I've just tried to look at it. I think I couldn't get it, but something that you may need to look up. So when it comes to hypertension, they are classified and defined as grade. And the optimum blood pressure is if somebody has a blood pressure of less than 120/80. So those are patients who you think, or people who you think they are actually having a good blood pressure. Once your blood pressure, and normal is between 120 to 129 and 80 to 84. And then there is also what they call high normal or elevated blood pressure, when it is between 130 to 139. I'm sure some of you are going to get surprised about this, even as with these definitions, you wonder if almost all of us are almost hypertensive. So and the cutoffs for this is, for the diastolic is 85 to 89. Yes, and then now this is when we get hypertension. So I want you guys to, if you cannot remember all these other, the optimal, the normal and high normal, just remember that hypertension begins when your blood pressure is above 140. And also when the systolic or and or diastolic. So hypertension, even if somebody just come with a diastolic blood pressure of 90 to 90, from above 90, that is still hypertension. So you don't only look at the systolic aspect of it. So, and then we grade this. There is a grade 1 when it is between 140 to 159, and also or, okay? So it's they are not mutually exclusive. And grade 2 when it is above 160, and then diastolic here is above 100, and grade 3 is more than 180, more than 110. And then you can have some patients who come with what we call isolated hypertension, and they come with elevated systolic blood pressures, but then their diastolic blood pressures are normal. This is quite common in the elderly patients, and this is because of the stiffening of the blood vessels. So the arterial vasculature. So what I want you to know is blood pressure. We consider it abnormal once it is systolic is above 140 and or diastolic above 90. And then there are different grades, and there are reasons why they are graded, as you will see when it comes to intervention. So I hope that is clear now. And there's also some other definition, or there is what we call white coat hypertension. And this is defined as blood pressure that is consistently elevated by office readings, but does not meet criteria for hypertension based upon out of office. So they've been there are these patients who come to let's say clinic. We call it, some people prefer to call it office, and then you check their blood pressure and they are quite elevated. But then when they are at home, if you tell them to check their blood pressures, then their blood pressures are normal. So I want you to be aware about this. And they've been thought that maybe, anxiety. Of course, these patients also get elevated blood pressures when they come to the office. They are at high risk, but not as high risk as what we call masked hypertension. So for the masked hypertension, it's like somebody is, when they come to the office, you check their blood pressure, it is not elevated, okay? But when they are at home, their blood pressure is elevated. And these are patients who've been shown to have high risk for end organ damage. And you might want to, the only thing that might suggest this is a patient comes and maybe when you're doing your workup, you notice that probably they have some, what you call hypertension mediated organ damage. For example, maybe they are coming with retinopathy, they are coming with hypertensive heart disease. For example, maybe in their ECG, you find that they have a left ventricular hypertrophy, and yet their blood pressure is normal. So this could be masked hypertension, where when they are at home, their blood pressure is elevated and they are actually at high risk for end organ damage and they need to be treated. For the white coat hypertension, they are at risk, but not as at high risk as this patient with masked hypertension. So I hope the two definitions are now quite clear. And when it comes to hypertension, we have risk factors. I would like to discuss with the class what they think are the risk factors that cause hypertension. I can see somebody called Sam Musau. What are the risk factors that can cause hypertension? I'm sure that's a very simple subject. Nobody? Anybody else?
So for the risk factors, we have the modifiable and the non-modifiable. So the non-modifiable can be gender, familial, age, and then for the modifiable can be hyperlipidemia, alcohol taking. Yes.
Okay, thank you, Metet. So basically that is it. So to some of those risk factors as she's mentioned, some you can modify, some you can modify. And as you can see here, I don't want you guys to forget about cigarette smoking, because that is really like when it comes to cardiovascular risk factors, cigarette smoking is like on top of the list. So always mention that, and also diabetes. And she's mentioned about dyslipidemia, and then there's also overweight and obesity, and physical inactivity, what we call sedentary lifestyle and unhealthy diet. And when it comes to relatively fixed, there is also CKD here. And of course, family history, there's nothing you can do about that, and increasing age. So as we age, the prevalence of hypertension goes up. And also some of the things that you may not do. So they call it relatively fixed, because maybe somehow you can modify some of these things. For example, low socioeconomical status, which has been shown to be associated with hypertension and MELSEC, and then obstructive sleep apnea, and then psychosocial stress. So when it comes to pathogenesis, nobody really knows what causes hypertension, but the thought is there is interplay between different mechanisms. And one of them is just there are environmental factors, and this environment. Somebody needs a mute, Bok. So when it comes to environmental factors, you think of unhealthy diet, sodium intake, that is increased sodium intake, and potassium. I want you to leave out of here knowing that actually potassium decreases your risk of hypertension. So taking that banana is not a bad idea after all. And physical inactivity, overweight, and obesity. And then now you have the genetic factors that probably there is multifactorial. There are multiple risk alleles. So there is no been a real gene that has been mapped and said this is the one that causes hypertension. So it is thought to be a many genes that are just come together. And also there's issues of epigenetics. And then when it comes to social determinants, there is the wealth and income, education that plays a role, and then also healthcare access. What we see in our setup is that, like in the Western world, is you find many patients coming for the first time actually with complications of hypertension, because they've never really seen a doctor, they've never had their blood pressure checked. Sometimes even you don't know what is their baseline blood pressure, they've never had one taken before. So so those are the things that can they all interplay together and cause hypertension. And when you want to check a blood pressure, how do you check blood pressure? This would be a take-home message for everyone, that actually first thing of diagnosing hypertension is making sure that you're checking the blood pressure properly. And the patient needs to be well prepared. I know this is not even happening in our clinics, but hopefully in the future. A patient just comes, they sit, they don't sit properly. You're talking to the patient as you're checking their blood pressure, which also can elevate their blood pressure. So the patient is supposed to be well seated with their back supported. I have a cartoon that will show that. And you are not supposed to be talking to the patient when you're checking the blood pressure. And then you need to use proper blood pressure technique to measure it. Make sure that the cuff size is correct, and that the arm is elevated, it's at the level of the heart. And also make sure that the BP machine is well calibrated, so that it is not giving you erroneous reading. And then the other thing is you need to take proper measurements that you need for diagnosis. And the first time when a patient comes to your office or clinic, then the best thing is to check their blood pressure, at least document the first time in the two arms, the left and right, because there are conditions that can give you the discrepancies. I will not go into that. And also and document the PP readings. So you're supposed to check more than once. I know in our busy clinics, here in MTRH, sometimes this is not happening, but when the situation allows, you're supposed to take at least 3 blood pressure readings. at 1 to 2 minutes apart, and then you need to average the readings and then give the readings to the patient both verbally. You tell the patient your blood pressure is this, and you can actually write for them. And this is very important because sometimes a patient comes and said, you know, I was just told my blood pressure was high. What was the reading? They don't know because the doctor never told them. So you need to communicate the findings to the patient. And this is how you're supposed to have blood pressure checked. And I think I'll just run through this. Like, first of all, do not have any conversation with the patient, because if the patient is listening to you, you know, listening also is stressful, then the blood pressure can go up. And make sure the arm is supported so that the patient can be comfortable. If it is just like swinging by the side, then you can have another reading added by about 10 millimeters of mercury. So as you can see, this arm is well propped. The patient is relaxed. And then you need to put the cuff on the bare arm. As you can see, this patient is not having any clothing. I usually see patients who have, you know, sweaters or some tight clothing, and then they just push it up, and that will actually make your blood pressure elevated. So you have to make sure that they don't have any tight clothing, and the best is if their arm is bare completely, so that you can take a blood pressure, and you can look at the correct blood pressure size, because it should at least cover about 80% of the calf circumference. And if it is small, then it can give you elevated reading. Also, if it is big, because sometimes we have this wasted patient and we use very big calf, and then their blood pressure seems low just because of the calf size. And then, of course, they are supposed also to sit with their feet flat and not crossed or hanging, because when you cross your leg, actually you increase your preload and it can increase your blood pressure. And if possible, of course, this is very key, because if somebody is coming with a full bladder, they might, you know, that is already stressful, and they can get blood pressure elevated, and the back has to be supported, as you can see in this slide. I hope that is very clear, because this is really what I want everyone to know. So when it comes to diagnosis of hypertension, it is recommended that you repeat office blood pressure in more than one visit. But if the blood pressure is severe, for example, if you meet somebody and you take a blood pressure and they're in the 180, 110, and you do all those repeats at least 3 times, 1 to 2 minutes apart, and you average them, and that is still the blood pressure, then you may want to treat such patient. You may not want to send the patient and tell them, come, we come and confirm. But when you get this blood pressure, let's say 140 to 150, and especially for somebody who is not on any high risk, for example, a young patient, they don't have any other cardiovascular risk, then you may want to, sorry, you may want to repeat again in another sitting. So, and then they say if the first 2 readings are different, like by more than 10 millimeters of mercury, then you may want to do another 4, and then you average. So there are also some ways you can diagnose hypertension. You can actually have patients do what they call ambulatory blood pressure measuring at home, which is like a 24-hour blood pressure, and then they can average that. But of course, we don't have such machines in our setup, but it is something that you need to know. And also they can just do home blood pressure measuring, you know, like at least twice in the morning, twice in the evening, and then they average that. So apart from but I decided to choose the office or rather clinic setup, because that is what we will come across most of the time. And if a patient comes with hypertension, I would like us to brainstorm about this. What would be your diagnostic approach? Yeah. Who is B okay? His microphone is unmuted, so maybe he can say, how do you approach in terms of diagnosis or in terms of evaluation of a patient with hypertension? Maybe John? Or any volunteer? I hope I'm not talking to myself. I hope you guys read something about hypertension. Mariam, sorry. How would you approach a patient? How would you evaluate a patient with hypertension? I won't proceed until you guys give me a reply, because that is the only way I can know you are in the Zoom. Because maybe some of you have just put on the Zoom and went to sleep.
Doc, do you perhaps measure the BP?
Yeah, you've already diagnosed that this patient is hypertensive. Sorry if the question is not clear. How would you evaluate further? Like, what would be the things that you will want to know? Are you in 4th or 6th year?
4th.
Okay. Maybe that would be a better question answered by a 6th year.
Doc, so we have diagnosed hypertension. So we are trying to find out the etiology. Like, okay, there are differentials that we'll have to rule out through different lab tests. For example, you can measure plasma renin, plasma aldosterone. You can do lipid profile to see, because we have seen amongst the causes we have had dyslipidemias. We can also do I think I've forgotten some of the other tests, but this test will help you to rule out the actual etiology, so that if it's, for example, it's dyslipidemia, you can start the drugs to control the lipid levels, the cholesterol levels.
A patient comes to the clinic. What is the usual way that you approach a patient? Just any other patient.
You take a history.
In terms of evaluation, yes, that is what I want to hear. And in hypertension, what kind of history will you be thinking about? What questions would you like to ask?
So history of smoking, lifestyle. So what kind of lifestyle do they live in terms of diet and exercise? Do they exercise regularly or not?
Okay. Would you be interested in family history?
Oh yeah, sure.
And apart from history, so what comes after the history? Let's proceed. Like, how would you systematically evaluate such patients? Charles, could you mute? Okay. Yes. So I'll just run through this because of time. And yes, so basically, so I want you to know that once you get these patients, the way to evaluate is just like any other patient. You take a good history, and you are very much concerned about their personal history, and you want to know their lifestyle. Because in this way, you're trying to establish its etiology. If you are getting somebody who is telling you, they smoke, well, they drink, well, their diet is, they are always in KFC, I know some of you love KFC, but then, you know, the problem with that is it can give you hypertension because they are usually, their food is usually very salty and refined. And also you want to see whether these patients are having any target organ damage. So you want to ask them if their vision is okay. And you also want to know the other risk factors that come with hypertension, as I can't remember, Mariam was talking about. You want to know whether, you know, they are diabetic, whether they have any other chronic condition that that will at least make you, you know, help you in terms of decision on how to treat this patient. And when you approach this patient with physical exam, you're looking basically for end organ damage, what you call hypertensive mediated end organ damage. And there are quite a number of those. So you want to see whether they are having retinopathy. You want also to see whether they're having things that you can say this is probably the cause of hypertension. For example, somebody who is having Cushing's syndrome, you know, you establish by looking at their body habitus. You also want to see whether they are having something that might suggest, you know, that it's secondary hypertension. You want to look at their thyroid. You want to see whether they are having a goiter that can suggest hyperthyroidism. You want to look at all these other signs of hyperthyroidism that can actually point to you what could be the causing this hypertension. So that would be the way to go. And in terms of basic labs evaluation, you want to see. So these are the testing that you have to do. If a patient comes to you with hypertension, all these tests that you must do. So you have to get their fasting blood sugar, you have to get their complete blood count, lipid profile, you have to check serum creatinine. So by doing blood glucose, you want to know whether they are diabetic, whether they are having dyslipidemia. By doing lipid profile, you want also to check their serum creatinine because of maybe these patients are having secondary hypertension. If in their history, maybe they don't know that they have, if they tell you in their history that they are on dialysis, then you can actually already think that this is a patient with hypertension, secondary hypertension due to renal disease. You want to check their serum sodium and potassium and calcium. What would point you, if you check their potassium and it is low, what would you be thinking about? Daniel, a 60, please. I don't know if Daniel is 60. If by evaluating this patient, you find out their potassium is low, this is a newly diagnosed hypertensive patient, what would you be thinking about? Okay, because of time, can we hurry up, please? Or anyone who wants to volunteer?
I think maybe hyperaldosteronism.
Yes, so that is actually the key. So by doing your potassium, if a patient is having low potassium, although they say quite a number of, not everybody with hyperaldosteronism come with low potassium. It might be actually on the normal range, but then maybe you can give this patient a diuretic and then, you know, in a few days, their potassium is really low. So it can be normal or on the lower normal, or it can be low. So that can point to hyperaldosteronism. You can also do a TSH just to check if they are having hyperthyroidism, urinalysis, just investigating the kidney, and ECG. And basically for ECGs, you're also looking for end organ damage and mainly signs of evidence of left ventricular hypertrophy. So these are optional tests. You can further, depending on how the patient presents, if you think they already seem to be in heart failure, then you can send them for echocardiogram and uric acid and urine albumin creatinine ratio to look for microalbuminuria, especially if they are having also diabetes. So treatment of hypertension is, first of all, you need lifestyle modification and also drug therapy. And for lifestyle modification, we recommend for everyone. And for drug therapy, we recommend combination when it comes to drug therapy. And it has been shown in many studies that if a patient is having a blood pressure that is elevated by more than 15 millimeters of mercury beyond their target, let's say if a patient comes with blood pressure of that in the 180s, it is unlikely by using one medication that you will actually control that hypertension. And what drug companies have come up with is that they have this combination pills that probably will come across when in your rotation. And but for patients which who are at low risk, like you get a young patient, maybe their blood pressure is in the 140, let's say in between 140 and 150, and you've given them, they have done lifestyle modification and it is not working, you reevaluate them in 3 months, you might actually decide for that one, you might give them one drug and decide maybe you give them a diuretic, a CCB, we'll discuss about this later. But now for these other patients who really have elevated blood pressure, you may want to start with combination rather than saying, let me start with, let's say, calcium channel blocker like amlodipine and keep titrating up. It is better if you bring on board 2 medications even from the beginning. So if a patient, so this is how you approach these patients. We talked about patients who are having this high normal, that their blood pressure is between 130 to 139, and on the lower side, on the diastolic aspect, is 85 to 89. So these patients, you give them lifestyle advice. So all of us will have to be on a good lifestyle, okay? If some of you are drinking a lot, then you know you are at risk for hypertension. So, so of course, avoid drinking, or there is some recommendation for, like, you know, 1 glass of drink for a lady and maybe 2 for a man, which is very, and you don't pile those up and say you're going to, you know, you have maybe 10 glasses because you've not been drinking throughout the week, and then you go and binge drink. Still not a good idea. So and if it is grade 1, the one we talked about, above 140, so you also give them lifestyle advice. And then in this category, you want to see whether they are having other risk factors, you know, for cardiovascular risk factors. For example, if they're having diabetes, if they are smoking, and if they also have evidence of hypertension mediated end organ damage, you want to treat, okay? So in this category, you give lifestyle advice, but also you go ahead and treat, especially if they are high-risk patients. If it is somebody who is as I gave you a scenario of just a young patient, no other cardiovascular risk, you might actually just offer them lifestyle advice and let them come back in 2 to 6 months and see. But if they already have many high risk, you want to treat even in this 140. And then, of course, these are grade 2, regardless. Even if this is a young patient, you start treating if their blood pressure is above 160 and diastolic above 100. And for patients who have also quite elevated, what we call grade 3, more than 180, you want to also do immediate drug therapy. So your take-home message is, if the blood pressure is above 160 systolic and diastolic above 100, you give lifestyle advice and then start medication. If it is between 140, if it is above 140 and 90, and the patient is at high risk, they're having other cardiovascular risk factors, or they are already showing evidence of end organ damage, then you treat. If not, then you can just offer them lifestyle and let them come back in 3 to 6 months. I hope that is clear. Any question around there? Because that would be the key thing that I would like you to go home with. Any question? Okay, so I'll just go ahead and proceed. And when it comes to non-pharmacological, one of them, the main thing is weight loss. For those patients who are overweight, if they lose weight, then they actually can come down by about 5 millimeters of mercury. And even if they are normotensive, even if your blood pressure is okay, you by losing weight, you also can come down your blood pressure can come down. And also there is what we call healthy diet. There is some diet that has been shown to actually help with hypertension. It is called dietary approach to stop hypertension. It was actually a study that was done, and it was shown that also among hypertensive patients, it actually reduces hypertension. And this is just consuming diet that is rich in fruits, vegetables, whole grains, and low-fat dairy products. And also you reduce the saturated and total fat intake. And this has been shown to decrease the blood pressure. Also dietary sodium, you want it less than 1.5 grams. I think that would be like a teaspoon in a day. Not so sure exactly, probably a nutritionist will know, but less than 1.5 grams is what we recommend, or 1,500 milligrams per day. And this also will reduce your blood pressure. And you can now understand why when we are talking to hypertensive, we tell them to reduce their salt intake. And we don't want them to eliminate it totally because we need salts. And then if you tell them to eliminate totally, then that is when they will come back with hyponatremia. So kindly let them just have some salt but low salt intake. And also you increase dietary potassium. We just discussed about this. Potassium actually lowers the blood pressure, and these are the ranges that you need to be at in a day. And when it comes to exercises, it's recommended that at least you do aerobic exercise between 90 to 150 minutes per week. So this translates to about at least maybe 30 minutes, about 5 days a week. Okay. So this is also help with lower blood pressure. And if somebody is also, there is what we call this dynamic resistance and isometric resistance exercises. And alcohol, it is recommended that it is taken in moderation. So that for men, it's less than or equal to 2 drinks a day. And for ladies, less than 1 drink a day. And I've warned you against trying to say that you're catching up with your alcohol and binge drinking. That is also detrimental. And when it comes to drug therapy, I would like at least a 60-year to tell me, like currently, what do they think that is an approach when you're starting antihypertensive? What medicines would you start with? Immaculate, are you 60-year?
Fourth.
Okay. Would you like to attempt, or you want a 60-year to attempt?
I can attempt.
Mm-hmm.
So for patients who have for patients who don't have diabetes, the first line drugs are calcium channel blockers and thiazide diuretic. And then that's the first line. And then if it doesn't work, you can add a beta blocker. And then for patients who have diabetes, the first line would be an ACE inhibitor or ARB. Yes, because it's vasoprotective for the kidneys. I think that's what I know.
Okay, thank you, Immaculate. So as you will see in this slide, actually, or a thiazide like diuretic. You can also use ACE or ARB. I know there's been some, like back in pharmacology, there's been some data to show that Black patients don't respond well to ACEs or ARBs. And then I'm just talking about a patient who I'm not specifically going into the population of diabetes. Although for diabetes as well, this is your choices of antihypertensive, the CCB or a diuretic in the Black population, okay? So gone are the days when you are thinking of ACE and ARBs that it is protecting, unless they're already having evidence of kidney damage, is when now you bring this, or if they have evidence of microalbuminuria, which is early evidence of nephropathy, then you can consider starting this because it will they are nephroprotective. But just empirically saying, because this patient is diabetic, I want to start them on ACE inhibit or ARB because to protect it is nephroprotective. That is not that is not recommended. So what has been shown also for diabetic patients is controlling the blood pressure is the most important rather than even the method that you use, okay? And these are your first choices, and they talk about initial therapy to be dual combination. So you may want to combine the CCB and an ARB or an ACE. You never combine ACE and ARB. I've seen a patient who's come to our unit with actually the two drugs together. It has been shown that this is harmful. So my take-home message, what I want you people to go home with, is never combine ACE and ARBs because they work in the same way and it is actually harmful to the patient. So you combine with a CCB or a diuretic. So CCB is the key in the studies that came, big studies showed that calcium channel blockers is the main drug there. And you combine it with either the diuretic or as an ARB. So for those patients you want to do monotherapy, you can decide either to do a diuretic alone, a thiazide. Actually, the ideal diuretic that you're supposed to use is what we call chlorothalidone. Unfortunately, we don't have it, but we have indapamide. So hydrochlorothiazide is because of just our resource limited setup. That is why we use it a lot, but in most studies, that is not what was used. And if this doesn't work, then you have all the three drugs together, okay? ACE inhibitor or ARB, and then calcium channel blocker and diuretic. So the thiazide like diuretic. So this is the step 2, triple combination. And then after that, if this doesn't work, then this is what we call resistant hypertension. So if a patient is already on these 3 medications and it includes diuretic and you have optimized, let's say it was amlodipine, you've gone all the way to 10. ACE inhibitor, you've optimized, you are at the 100 range. Let's say for enalapril, maximum dose is 40. And for ARB, maximum dose is, let's say about 100, for losartan to 150. So you've gone all the way to those almost max and the patient is still having hypertension. Then this is what we call resistant hypertension. And when you're in resistant hypertension, then you add spironolactone. So I can't remember the name of the student who was talking about this. So you can see your beta blocker is very far. It's actually at the bottom of the list, okay? So this is your approach. When it comes to resistant, add aldactone. And of course, when you're treating these patients, you have to know that if a patient is having hyperkalemia, you cannot be starting the ACE inhibitor or ARB. So maybe you will have, you may bring in these other drugs earlier than for patients who don't have any, contraindication to ACE. And if a patient gets angioedema or they get the chronic cough, so never forget that when you start this patient on ACE inhibitors, enalapril, they start coming and telling you they have irritating cough, then that could be side effects of ACE inhibitor because of the way, because of the, I forgot, because of the side effects and the way it works by inhibiting the angiotensin enzyme and causing buildup of the substrate in the lungs, and then it gives a cough. So for the beta blockers, there are other indications. Now, let's say somebody is having cardiovascular, they have gotten an MI. So in these patients, if they have hypertension, you want to bring the beta blockers earlier. So for patients who have heart failure and angina, post-MI, and maybe they have atrial fibrillation, or they are younger and they are pregnant, because in pregnancy you can use ACE inhibitor. So there are exceptions where now the beta blocker will be your drug of choice. So for example, if a patient comes and they are hypertensive and they are already in heart failure, so as we discussed last week, so approach to heart failure. So when you're also doing that approach to heart failure, you have to consider, okay, if this patient is hypertensive, because I need this for the heart failure, then that would be your drug that will come on top of the list. And as I said, if somebody is having already element of nephropathy in terms of, for those who have diabetes, then you want ACE or ARB to come on top of the list. I hope that is clear. Yeah, so as discussed in the previous slide, so if a patient, what do we call resistant hypertension? So it is defined as blood pressure that is not controlled or to goal despite adherence to an appropriate. So when you want to say somebody is resistant, some of these are what we call pseudo-resistant because the patient is not taking actually the antihypertensive medicine as required. So once the patient actually is taking the antihypertensive, they are on three different antihypertensive drugs from different classes, including a diuretic, and they still have elevated blood pressure, then it can be defined as a resistant. But remember, you have to exclude also the what you call the white coat hypertension that we had discussed earlier. And so since these are some of contraindications, so when you're studying your medicine, this time I did put slides on the specific dosages. I thought that I'll leave that to you so that you can go and, because the drugs are quite many. When it comes to diuretic alone there are quite a number. So I thought this will be your homework to go and look at actually at the dosages. But in terms of contraindication, if somebody is already having gout, kindly avoid thiazide or thiazide like diuretics because they are known to cause hyperuricemia. And beta blockers, especially if a patient is asthmatic, you need to avoid the beta blockers, especially what we call non-cardioselective. And also, if somebody is having bradycardia, so when you're studying this patient, that is why you need a resting ECG. And when you're evaluating them also, you're also checking the radial pulse to know. So you have to avoid beta blockers in a patient with bradycardia. And calcium antagonists, as you can see, there is really no compelling contraindication. But if a patient is having tachyarrhythmia, you may want to avoid it. And this is dihydropyridines, which is amlodipine class, and nifedipine. And if somebody is having heart failure with reduced ejection fraction, avoid nifedipine. I want you guys to know that we don't use it in heart failure. But amlodipine is neutral in heart failure. But it is something, just have it in your mind that it is a relative contraindication when somebody is having heart failure, reduced ejection fraction, to start, especially nifedipine. We do use amlodipine if we have optimized the other medication and the blood pressure is still elevated, because amlodipine is neutral in heart failure. And calcium antagonists, the others, verapamil and tretinoin, you want to avoid them if somebody also is having LV systolic dysfunction. So calcium channel blockers, think of somebody who is having heart failure, reduced ejection fraction as one of those contraindications. And then among those medications, as time goes by, you will know which one you can use. So what is neutral is amlodipine. So I want you to, especially the 60s, to know that. And the problem with this verapamil and tretinoin is it can give you a lot of constipation. And then for ACE inhibitors, you never use them in pregnancy, and you don't also use for patients who've had angioedema and those who have bilateral renal artery stenosis. And of course, you avoid them also in ARBs in pregnancy. So when do you suspect secondary hypertension? So you have this young patient who is coming, they are less than 40 years and their blood pressure is quite elevated. Or if they have had any onset, any grade of hypertension in childhood. So all those patients who are coming and they're 18 years, they're 17 years, and they are hypertensive, kindly think secondary hypertension. And also for a patient who's been previously controlled, you're having this lady who blood pressures has been okay, and then all of a sudden the blood pressures are poorly controlled. So also you suspect that they could be secondary hypertension. And then all this, we discussed about resistant hypertension. Every time you find that you've titrated your antihypertensive and the blood pressures are still elevated, think of secondary hypertension. And any patient who presents with hypertensive emergency, also consider secondary hypertension. And a patient comes with, and then they already have extensive end organ damage, hypertensive related end organ damage, and you think also secondary hypertension. So basically, hypertension that is already complicated, or hypertensive emergency, or hypertension in childhood and worsening of normally of a blood pressure that was well controlled. And also, if when you're examining the patient, you see other signs that are suggestive. For example, somebody presents with what look like signs and symptoms of your chromocytoma or the hyperthyroidism. So you have to think of secondary hypertension. And these are the most common causes: obstructive sleep apnea. So you have these obese patients who have short neck, they snore in their sleep. Think that could be the cause of their hypertension. And even if you continue treating and titrating antihypertensive, if this is not addressed, if they are overweight, they need to lose their weight so that they can breathe better. And also renal parenchymal disease. I think we see a lot of this in the ward, these patients who are having hypertension because they are having renal parenchymal diseases. And renovascular disease, if a patient is elderly and they're already having what we call atherosclerotic cardiovascular disease, you also consider that maybe they're having atherosclerotic renovascular disease. And young patients, they can be having fibromuscular dysplasia. So this is in the range of 1 to 10%. Other causes are primary aldosteronism that we discussed before. Patient comes and they are having low potassium or low normal potassium. Pheochromocytoma, you know how they present with episodes of sweaty. Their blood pressures are labile. You know, it keeps fluctuating from 180 to 100. Think pheochromocytoma, and then the Cushing syndrome and thyroid, and also consider coarctation of aorta, especially among young people. And for this, you will suspect if their blood pressures or their pulse in the upper extremities is quite strong, and then when you palpate their pulse in the lower extremities, is diminished. Okay, so these are some of the complications of hypertension. Of course, first is left ventricular hypertrophy, and we discussed in the last class that this can proceed, it can cause heart failure, reduced ejection fraction, or heart failure. Initially, it is heart failure, preserved ejection fraction, but as time goes by, the left ventricular functions get burnout, and then it becomes heart failure, reduced ejection fraction. Patient also can come with hypertensive emergencies with intracerebral hemorrhage or ischemic ischemic stroke. They can also get ischemic heart disease. They can come with acute myocardial infarction and also chronic kidney disease, and don't forget hypertensive retinopathy. So I was not able to go through this, but I think you're reading, or I don't know if you've covered this in ophthalmology, but you need to know all the classes of hypertensive retinopathy stages. And hypertensive crisis, I will want you guys to define that before we are almost finishing the class, but one person, Ahmed, could you define the hypertensive emergency?
Hypertensive emergencies when you have high BPs, extremely high BPs, and end organ involvement damage.
And the urgency?
Urgency is without the end organ damage or involvement.
Okay, you're 60 or 4th year?
4th.
Okay, very good. So so as Ameda said, you just have extreme elevated blood pressures, and they based on the diastolic. So they say severe hypertension, diastolic above 120, with evidence of end organ damage. So just think diastolic. They used to give systolic ranges, but from the source, and this was up to date, they did not give the systolic. So you just know that the cutoff is the diastolic blood pressure that they're using at 120 millimeters of mercury, and if they have evidence of end organ damage, is when it is an emergency, and urgency is without end organ damage. And this is how you would want to diagnose a patient. Like, you want to work up the patient with hypertensive emergency. You want to check, do fundoscopy, see whether they are already having signs of retinopathy, especially papilloedema in the acute setting, and 12-lead ECG looking for evidence of acute myocardial infarction and the laboratory results. And also creatinine, you're looking at evidence of acute kidney injury. And these are just things that you're supposed to do. These are the basic tests. And then also depending on what you suspect, for example, if you're suspecting somebody's having acute aortic dissection, you may want to order CT angiography of the chest or abdomen if you're suspecting. So of course, I believe you've in the history defined, you know, how somebody with aortic dissection would present. They are having this tearing pain. You might check their blood pressures. They may have discrepant blood pressures depending on where the dissection is. And you may also want to do a echocardiograph. You can actually see proximal aortic dissection in echocardiograph, in transthoracic echo, and then check for evidence of heart failure and ischemia. That is how you would approach. And there are some hypertensive emergencies that you want to lower the blood pressures within hours. Okay, like somebody with malignant hypertension, and this is defined as acute elevation in blood pressures to extreme levels, and they can have evidence of acute kidney injury or not. So you use the mean arterial pressure to lower the blood pressure. And so to get a mean arterial pressure, you add the systolic systolic blood pressure, and then you times by 2 the diastolic blood pressure. It is something I want you people to check today, because in these hypertensive emergencies, that is what you use sometimes. So you add and then you divide by 3. That is when you will know what are the mean arterial pressures. If somebody is having hypertensive encephalopathy, you reduce also blood pressure by MAPs of by 20 to 25%. Acute coronary event, those patients coming with myocardial infarction, and these are the medicine that you can use. Acute myocardial infarction, you may need to come to blood pressure less than 140. If somebody is having pulmonary edema, you also want to come to less than 140. And pulmonary edema, remember, you want to vasodilate you want to reduce the preload by using vasodilators. So you use nitroglycerin. There used to be a mnemonic for acute pulmonary edema, which was it included the morphine, oxygen, and nitroglycerin as part of it, and diuretic. And aortic dissection reduce blood pressure to less than 120 and the heart rate of 60. So for acute aortic dissection, we usually use IV beta blockers mainly, and then you can add the other medicine when you don't get target blood pressure and the heart rate. And of course, we know the eclampsia and severe eclampsia. You are using labetalol and also magnesium sulfate. I thought I should put this. I don't know, because I was covering hypertension. I didn't know whether I needed to cover the emergencies as well. But I have noticed that many people, when a patient comes with acute ischemic stroke, they really try to aggressively control the blood pressure, and that is wrong. Because there is the penumbra that could be still be viable in the brain, and then when you lower the blood pressure, then the stroke extent actually become worse. So if a patient is going for IV thrombolysis, and these are patients who present less than 3 hours, or sometimes we allow up to 4.5 hours. Then they can be thrombolyzed if they have acute ischemic stroke. And if they need to be thrombolyzed, then you only want to control their blood pressure to less than 185 over 110. So look, it is pretty elevated blood pressures. So that is the only time that you want to control. If it is no, you only reduce their blood pressure if it is more than 220 over 110. I know some of you will get scared about this, but please, if you see acute ischemic stroke, don't aggressively drop that blood pressure. Just control it if it is more than 220 over 110. And then this is how you lower it, just by 15% during the first 24 hours. So it is still very gradual reduction. So after 72 hours, you can start lowering those ones who had their blood pressure less than 220/110. But within 72 hours, please don't touch that blood pressure if it is elevated, unless the patient is being planned for thrombolysis, which of course this can be done in a critical care setup like CCU. I hope that is very clear. And for in pregnancy, I just thought I should mention this. We only, if a patient is having symptoms and they are also having evidence of end organ damage, if their blood pressures is more than 140/90 is when we start bringing it down. So it's just like the other patients. But if they don't have any other, if they don't have any symptoms or they don't have any evidence of end organ damage, so we let them have some hypertension. So we just control when it is about 150 and 95, okay? And then these are the drugs that we use: methyl dopa, labetalol, and calcium channel blockers. All the patients who are pregnant, we avoid ACE inhibitors and ARBs because they are teratogenic. So we sometimes get patients who on this medication and they get pregnant. Of course, like any childbearing women, and you have them on this medication, please talk to them and tell them that if they plan to get pregnant, that they should let you know so that you can actually switch them. So we've had patients, young patients who are on this medication, we switch them to CCVs and beta blockers before, you know, they get pregnant. At times, of course, unfortunately, they get pregnant on this and we have to withdraw them. And the PP blood pressure thresholds, I just wanted you to know that this is an American guideline. Your take-home message is you want to reduce blood pressures to about 130/80. There have been some guidelines which was talking about 140/90, but just have it in mind because the lower the better. But again, you want the blood pressure to be in this range of 130/80. If a patient is in heart failure, all these other conditions, ischemic heart disease, secondary stroke prevention, if somebody has had a stroke, if they have chronic kidney disease, lowering blood pressure more than this again is dangerous because it has been shown to result in hypertension and kidney injuries as well. So you have to try to get into around this range. I know you will see our heart failure patients are having blood pressure probably much lesser than this, but we are trying to balance by introducing the heart failure medicine that they also need. But for the other patients, we try to stick around this range, 130/80. So that is the end of my discussion today. Thank you very much for listening. If there are any questions, I would be glad to take them.
Okay, I have a question, Doc.
Yes.
In routine BP measurements, why is it recommended to use the non-dominant hand?
Non-dominant. Okay, it's not about non-dominance actually. It is just because we assume that the left arm is closer to the heart. Okay, and most of the time, actually, the left arm has it's thought to be the one that has probably more elevated blood pressure than the right arm, which is quite distant from the heart. But what I said about checking blood pressures in the two arms, like in the first instance that you see a patient, then you will choose the arm that has a higher reading. Of course, we are hoping that if the reading is quite discrepant, also you have to think of other things like, you know, is this patient having dissection, or you know, this connective vasculitis, for example, for somebody like who is having Takayasu, what we call pulseless, you know, so they can have that. So you, of course, you will think further if the discrepancy is really like more than 10 millimeters of mercury. But that is the thought. So that's why we use left arm a lot. So it's not because it's non-dominant, but it's because of the physiology. aspect of it.
Oh, it's okay. Thank you.
Welcome. Anyone else?
I have a question.
Yes.
So in the case of the wards, you say that the BPs we take when the patient is seated up and resting at the back resting. Now in case of the wards, we do not have that setting. So what do we do there?
Okay, yeah. So remember also the discussion was when you are diagnosing hypertension, okay? So the patients in the ward, that is not possible. That is very true. And even in the clinics, that is not what you do. But remember, this was when you are actually diagnosing hypertension, okay? So it is not like for patients who we already know they are hypertensive. So of course, what we are practicing like in the ward is not the best, but also, that is what you can get. Like if you have a patient in CCU is in a monitor, there is no way you will sit up that patient and start, it's not possible like in inpatient. But I just want to point out that this was really when you're diagnosing for the first time, like when you're seated in your office, that is how you should measure the blood pressure, ideally. But we take what we get.
Okay, thank you.
Okay.
I have a question, sorry. Hello.
Yes, I'm listening.
Oh, thank you so
Yes.
much for the one. Thank you so much for the wonderful class. I have a question. How do you go about a person who has an isolated hypertension? And let's say the discrepancy is too much. Like, for example, you have like 160, but the diastolic is normal. And also the other question is, how often do we see, what's the prognosis of someone who has grade 2, grade 3? Is it possible with lifestyle modification and also with time? Is it possible to win them off medication, or they have to be with the antihypertensive for the rest of their lives? Thank you.
Yeah, that's good. Those are good questions. So the first question is systolic hypertension. Okay. So as I said, that especially for patients as we grow older, then the arteries become stiff, and you get isolated systolic hypertension, especially in the elderly. It's usually a little bit difficult to control, but we still approach them the same way that we do for any, because remember, even hypertension by definition is either systolic. If somebody comes with 150 over even 60, of course you're thinking also of the causes of white pulse pressure there. But you just approach them the same way you approach the other patients and start the antihypertensive. When it comes to grade 2 or grade 3 hypertension, it depends, okay? Some patients will continue having their blood pressure, but you see, it can be that their lifestyle was the problem. So start the medicine, let them have the medicine as they change the lifestyle. As you could see that in the approach, lifestyle is always like a standard for everyone. Because even if you use the pills, it may not work if somebody is still having their bad lifestyle, they're still taking a lot of salts. And once their blood pressures is normalized, like you can have patients who have blood pressures in the 130s for 1 year, and then the blood pressures start coming down. So you start titrating the medicine. Remember, if you're already on the 3 medicine, you can start removing one by one. And maybe in the end, you maintain just a diuretic. And if they can continue having normal blood pressures, you can consider actually withdrawing the drug. So at times I've had patients that we've withdrawn medicine because, remember I told you that be careful when you're treating somebody with hypertension. I think sometimes we approach these patients, we are not too careful, because you can get a patient who is young and their blood pressure is 110 over 60. Probably that patient you should be thinking of titrating, coming down from the medicine by removing one if they are on 2, or if they are, you can just remove that one and see how the patient does. And what I encourage patients to do is to check their blood pressures at home. they come with a book, at least, with some recordings of the blood pressures they've had at home. And that can help you when you want to titrate the medicine, so that you can also rule out, the mask hypertension, the fact that they come to the office and their reading is normal, and when they are at home, their blood pressure is elevated. I hope that answers you. I can see there's a question about, do you diagnose orthostatic hypotension on the chat, and from Metet. So orthostatic hypotension is actually very important, especially when you're titrating the medicine. And you have this patient lie down, and then you check their blood pressure, okay? And then you check the blood pressure again when they are standing up, like within about 3 minutes. And then you see whether there is drop in their blood pressures. If there is a significant drop of about 20 millimeters of mercury, I believe it's 20 millimeters of mercury in the systolic blood pressure, then that is orthostatic hypotension. And the best is if the patient also complains of symptoms when they stand up. So that is it. Some patients may not actually, and the reason for that is when you stand up, then your preload decreases because of the pooling of blood in the lower limbs, and then you decrease your preload, and then Frank Starling forces, of course, come into effect, and you have less preload and less blood pressure. And also, ideally, you should the parasympathetic and the sympathetic response should be very strong. Like when you're standing up, your heart rate, there should be vasoconstriction, and your heart rate also should go a little bit up. But so for some patients, they are not able to have adequate sympathetic response, and they start getting orthostatic hypotension. At times, their heart rate might actually go up by about 30 beats per minute. So it may not just be the blood pressure that dropped. Maybe the blood pressure maintained a little bit or dropped less, but then they are very tachycardic. So that also can be a sign of orthostatic hypotension. And the other question is, can hypertension be treated to complete resolution, or the patient will have to use the medicine for the rest of their life? I think I've explained that as you see, you keep reviewing this patient 3 to 6 months, and if their blood pressure is normalized. Now remember what we've seen people do, like in terms of mistakes that they do. You have a pregnant lady, they come with the PET, you tell them, they deliver, you tell them, now you're cured. The blood pressure results, you tell them you're cured, go home. You can see this patient the next time coming with a stroke, okay? So my take home here is, when you have somebody who's ever had hypertension, follow them up. Like that mother who delivered and they had PET in pregnancy, the chances of them having hypertension in future is very high. That is already a risk factor. You want to check the blood pressure, maybe every 6 months or every 1 year, or depending on where the range. You see, if you already see they are on the pre-hypertension, they are in the 130s, you may want to check it, tell them to check their blood pressure more frequently. If it is lower than that, maybe less than 130/80, you may tell them, check it every 6 months or every 1 year. When you start seeing the blood pressure getting elevated, then you may want to do frequent checks. So for these patients also who are hypertensive, don't tell them that they've been cured. Tell them that the blood pressure is now normalized. We can see what we can do. Continue with the lifestyle management. We can hold the antihypertensive and see how you does, and keep following them up. Any other question? Okay, so that would mark the end of the hypertension class. It's quite a broad topic, so I tried to cover what I thought is important. So that means you guys still have to read around it. You can also look at the Kenyan cardiovascular guidelines on hypertension. It has actually all the cardiovascular diseases, and you can do other reference to UpToDate and other guidelines that are out there. So thank you so much. Have a good day.
Thanks, Doc, for the presentation. We'll check for the signing of the attendance. Thank you. Have a nice day.